This podcast is for informational and educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult their personal healthcare provider.
From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm Steph Dewar, Director of the Pediatric Residency Training Program and member of the Hospitalist Division. Happy that you're back with us today.
And I'm John Williams, Chief of Pediatric Infectious Diseases.
We're here today with Dr. Carlton Bates, who's the Chief of the Division of Pediatric Nephrology and Vice Chair of Basic Research in the Department of Pediatrics. In addition to caring for children with pediatric kidney disease for many years, Dr. Bates has a well-recognized research program focused on genetic regulation of kidney and bladder development with nearly 20 years of continuous funding from the NIH. Welcome, Dr. Bates.
Thank you. Glad to be here.
Well, we're so curious to hear about what are the types of patients that you're here at Children's taking care of.
We have quite a wide range of children. Sometimes people might ask, what does a pediatric kidney doctor do? It is somewhat a specialty of rare diseases, but some of the more common things that we see patients we take care of are those that have problems with hypertension and kidney stones or crystals in the urine. So those are probably the two major populations. And then one might ask, well, why would we care for patients with hypertension? And that's because a significant portion of children that have hypertension have something wrong with their kidneys, either compromised blood flow, a scar in their kidneys. Now, unfortunately, these days, an increasing cause of hypertension is primary related to obesity, as well as genetics, which that is our most common diagnosis. So I'd say those are the two primary conditions we see. Certainly, we have many other patients that have proteinuria, hematuria, more rare genetic types of diseases. So it is an interesting specialty. We do have quite a spectrum of patients that we see. We never quite know when we're going to clinic exactly what we're going to see.
So we'll get into this, Carl, when we talk about your research in a couple of minutes, but it sounds like from what you're saying that there's also a lot of ways that things can go wrong in the kidney, either in the way it forms, the way the plumbing is sort of connected, or the way it functions. Is that these rare diseases you're talking about?
Right. So it can range from, as you said, there are genetic diseases leading to malformed kidneys. More often than not, we don't understand the genetics. We know there's something wrong with the genes, but it doesn't follow a typical Mendelian inheritance pattern. So many of the causes, like posterior urethral valves, which is the number one cause of structural disease leading to end-stage kidney disease, we don't even understand what valves are at an embryologic level. You're not supposed to have them, and somehow these things appear. No one is even sure exactly what they are, why they appear. Whereas there are other clearly defined genetic disorders. Some of that has to do with just our knowledge base increasing. So, for instance, there are nephrotic syndrome, inherited forms of nephrotic syndrome, that we've known about for some time, but then there have been others that we thought were more sporadic that we've identified that no, in fact, they are monogenic forms of nephrotic syndrome. Probably well over 20% of patients that in an early stage that have nephrotic syndrome have a genetic cause. So the genetics, the mutations that you see can lead to problems with glomerular formation, tubular function, overall kidney architecture that doesn't form right, vascular problems within the kidney. So yes, there are quite a wide range of things that can go wrong.
So most of the patients then that you see on an ongoing practice in your clinic, are these patients who have underlying disorders of structure or function, or are these new referrals from out in the community?
Well, probably about a third of the patients we see in clinic are new, and the others are patients that we continue to follow. The frequency with which we follow up patients depends on their underlying condition. There's some that have relatively minor conditions like persistent microscopic hematuria that we'll see probably on a yearly to every other year basis, to those that have advancing chronic kidney disease that we'll see as frequently as every other month. So it really varies. I'd say on average, most of our patients we see at about every 6 months or so. The average patient with kidney stones that has hypercalciuria will follow on about a 6-month basis, or patients with hypertension every 6 months to a year. The rest of them, as I say, it really varies on what their disease state is, what their underlying disease state is, as well as how progressive it is.
So I'm wondering what your current research interests are and what exciting news you have to share about that front.
So most of my personal research has focused on the molecular control of kidney development, kidney and lower urinary tract development. And one might ask, why do we care? Well, if you look at the leading causes of chronic kidney disease, about half are structural. And among that half, it's split fairly evenly into aplasia, dysplasia, hypoplasia, meaning that it just didn't form right. The kidney didn't form right. The other half are plumbing problems, that something is obstructing urine flow, posterior urethral valves, ureteropelvic junction obstruction, UVJ obstruction. So those two categories make up over half of the cases of patients with chronic kidney disease leading to end-stage kidney disease. So to make an impact on that, so you might say, well, we have treatments. We have dialysis and transplant. That's effective, right? Not really. There are no cures for end-stage kidney disease. If you are unfortunate enough to be born or to be a child, we won't even go birth. Birth is worse. A child and you develop end-stage kidney disease, you lose on average 50 years of life. 50 years of life on dialysis. Well, we can transplant them, right? We can do a lot better. Well, you only lose 25 years of life if you get a kidney transplant. Your quality of life is much better. When we provide dialysis for patients, you give them basically enough kidney function back with dialysis so they don't die, is really the truth of the matter. If your GFR is below 10 mils per minute per 1.73 meters squared, you're going to die. We give them enough dialysis that we're barely above 10. So imagine that you're a child. You're trying to grow, thrive, learn, go to school, when you have almost the level of kidney function provided that you don't die. And it actually speaks to one thing about our program that I think that I'm very happy about, is which we are a very aggressive kidney transplant program. We, despite the size of Pittsburgh, we're probably in the top, we are in the top 10, if not the top 5 for the number of patients that we take care of that have end-stage kidney disease. A large portion of those come from outside of Pittsburgh, Buffalo, Morgantown. They send all of their kidney transplants to us. In fact, we have patients that have come from 18 states outside of Pennsylvania for kidney transplants, including programs that have transplant programs, but they just feel the patients are too complicated or too small, medically complex to transplant. So we have a very small chronic dialysis program, and I'm proud of that because we don't let the kids languish on dialysis. We transplant them. But even that said, transplant's not a cure either. It's better. You feel better. You now have 50 to 70% GFR, but you still have problems and you still die young. So, unlike cancer with our 80% cure rates, we have 0% cure rates for end-stage kidney disease. So that's why I think looking at my point of my research, what I always put in for my significance sections is these very issues that we have palliative care for end-stage kidney disease. If we want to make an impact, we need to figure out what goes wrong with kidney development and what can we do to make it go right. As an extension of my work related to understanding the molecular control of kidney development, and this is really in the mouse. So we've made lots of mouse models where we manipulate gene expression and we reproduce the kinds of structural kidney disease that you see in children. So absent kidneys, duplex kidneys, hypoplastic kidneys, dysplastic kidneys, cystic kidneys. Well, that's all well and good, but how do you take that into do something that's translatable? I've been working recently with a team, including members of the McGowan Regenerative Institute at Pitt, on looking at can you regrow a kidney in a dish? And there are lots of people looking at this now, but my collaborator, Eric Lagasse, floored me when he showed that he could take an embryonic mouse kidney, mince it up, inject it into a host lymph node. It reconstituted kidney tissues that were perfused, that entrapped a fluid that concentrated urea. The only fluid that concentrates urea is urine. He made functioning kidney tissues within a lymph node. This is stunning to me. And so we're working with him now on, well, that's great. You take minced embryonic kidneys. We can't really do that as a source. Can you get progenitors? And so there's a large movement in the research community looking at induced pluripotent stem cells and converting them, driving them to a renal fate. The kidney's complex, though. It's not like, not to denigrate other organs, but a liver cell where you take a hepatoblast, you make that an hepatocyte. Well, the kidney has really 4 different progenitor cell types that all need to be present. The nephron progenitors that make nephron epithelial cells, of which there are 21 different epithelial cell types. That's complicated enough. A ureteric epithelium, which is the progenitor for the collecting system. And those two need to be cross-talking and signaling to each other. Then around that is a renal cortical stroma that acts as kind of an organizer for all this to work. And then, of course, you need blood vessels, many of which are coming within the kidney. So there are people out there that can make nephron progenitors grow into these blobs that kind of have epithelial structures, but we're looking at the lymph node as a bioreactor that has these amazing organizing properties. The lymph node can organize liver cells, beta cells in the pancreas to make functioning tissues. I mean, if you think about it, cancer is teaching us that, right? How does cancer spread through the body? Through the lymphatic system. They've known that the lymph node's a potent bioreactor for some time. So we're trying to harness that capability to say, let's take your favorite iPS cells, make them into nephron progenitors, make them into ureteric cells, combine them together, put them in the lymph node. In fact, we're actively now talking to a group from Japan that has done some really successful research doing exactly that in a dish, but they can only go so far. These tissues that they're combining in a dish, while they kind of look like early kidneys, they're really fetal kidneys. They don't mature. If they grow them longer in vitro, they just turn into fibrotic masses and die. They're not perfused. So how do you really test for function? You need perfusion to then look at urine production, glomerular filtration, and then tubular function. So we are working with groups like this now in the lymph node. So I find that to me is really exciting work, and we're of course the challenge is always getting external funding agencies to be as excited. That's one piece that I'm working on. The other piece is I've fallen in love with the bladder. I never knew I would fall in love with the bladder, but I have. And it's a very important organ if you're a nephrologist. If you don't have a functioning bladder, your kidneys aren't going to be very happy. And actually, there's a real lack of intensive research at a basic science level looking at bladder disease. Urologists are very talented people, but they're mostly clinically focused, whether it's they're straight up clinicians or focused on clinical research, not really interested in laboratory research as much. So there's a real big problem out there, which is that bladder injury happens a lot. One example is cyclophosphamide. A great drug helps cure patients that have lymphomas or that have bad types of glomerular disease or rheumatic disease, but there are problems with it. And one is that a toxin called acrolein accumulates in the urine, and it leads to direct bladder toxicity, leading to hemorrhagic cystitis, and more importantly, bladder cancer. There was a large study, survivor study, patients with lymphoma, 6,000 of them, that overall had a 4.5-fold increased risk of bladder cancer. If you stratified them by dose, those that got the highest dose, which is 50 grams or more, had a 15-fold increased risk of bladder cancer. This is despite all the stuff we're currently doing. Mesna, which binds acrolein, hydration. What we're doing isn't working. So, and no one's really looked at this. How does acrolein cause bladder toxicity? What does it do? And is there anything we can do about it? We have some really interesting research looking at exactly that topic. We are specifically interested in how fibroblast growth factor receptors might play a role in disease or even in therapy for patients that have this bladder disease. Well, why would that be the case? It's been known for some time that keratinocyte growth factor, FGF7, is a potent epithelial mitogen. And if you give too much, that actually can cause hyperplasia and even cancer. But it's also been shown in many wound healing studies, oral mucositis, lung alveolar injury, gut injury models, both preclinical and some clinical models, that if you give patients keratinocyte growth factor, patients or animals, that it largely ameliorates injury. So we started looking at that in the context of the bladder. There was actually a paper, the last one in 1997, that's the last one, that somebody looked at this. And there was a paper, a preclinical model that suggested you give a patient Cytoxan, give a mouse, give a rat Cytoxan. They get horrible hemorrhagic cystitis. You give them a single dose of keratinocyte growth factor before Cytoxan. And they said you largely regenerate the urothelium. You accelerate regeneration. We started looking at this, and they're not quite right. What actually happens is, and we've shown this same thing, it's incredible. If you give a mouse a single intraperitoneal dose of cyclophosphamide and a dose that's equivalent or similar to what you would give a person, they get horrible hemorrhagic cystitis. And we actually have to look at the females because the males do, as is most often the case, much worse than the females. We don't even look at the males. So we look at the females, and even they have a terrible hemorrhagic cystitis. If we give a single one subcutaneous, which is like giving an IV dose of keratinocyte growth factor, we almost completely block the injury. Block the injury, that's the key. It's not accelerated regeneration, we block the injury. So what we find is that actually the acrolein, which hits these superficial cells in the bladder, the urothelium, there's the outermost layer, there's a necrotic cell death, they just slough off, and we don't block that. That happens within the first 0 to 6 hours. But from 6 to 24 hours, there's a second wave of death called apoptosis. That is almost completely blocked by keratinocyte growth factor. In those that don't have KGF, they go down, so that the urothelium is a multi-layered epithelium. You go down to just your basal layer, and sometimes completely denude everything. In our KGF treated, it's amazing. There's almost no apoptosis. And we've been carrying these studies forward to look at, well, you might say, are you protecting cells that you should let die? The answer seems to be no so far. We've carried the studies out to 3 days and now 28 days. We're looking to see what the architecture is. And so far, it looks pretty good. But we'll, stay tuned with that. There's the backside of this is that what happens if you knock out the receptor that binds to KGF? What happens to the urothelium then? Well, so as it turns out, if you do that, if you knock out the receptor, specifically, we can use fancy mouse targeting techniques to knock it out just in the urothelium. And we can do it in an inducible fashion. So we let these mice, they're born, they're fine. We give them what's called a tamoxifen-inducible, a hit of tamoxifen, which induces the deletion of this receptor. And in the quiescent state, that they don't care. It's fine. But we hit those with Cytoxan, and they don't do very well. They're not very happy. What happens is we have a maladaptive regenerative response. What happens is the basal layers, which are where the progenitors are, normally in the quiescent state, there are very few progenitors. After injury, they spread across the entire basal layer. And in the controls, they proliferate upward and replace the damaged tissue. But it's not a simple replacement. There's a lot of DNA damage that happens. And so they're sloughing the damaged cells, making new ones, sloughing, making. And this happens all the way out to, even at 28 days, it's not finished. Our poor mutants, on the other hand, they make the progenitor spread across the basal layer, but they are ineffective at producing progeny to replace the damaged urothelium. What they do is they get trapped in a process called endoreplication. Well, what is that? They go through the cell cycle, but they bypass mitosis. So they make big fat nuclei. They make more DNA, but they don't divide. So they get these giant cells with these giant nuclei that don't divide. So we find this very fascinating. And actually, we are starting to even understand the mechanisms by which this occurs. We're understanding now that they're different. Of course, these receptors signal through different downstream pathways. The KGF overdrive anti-injury protective effect seems to be on one pathway called AKT. The problem with regeneration in the mutants seems to be ERK mediated. In other words, ERK represses endoreplication. So anyway, this is where we are with that. Probably more detail and depth than you wanted to hear.
I am so happy that you're in love with the bladder. I have merely made peace with my bladder and learned to live with it every day. But that was more thinking about bladder cellular activity than I think I've ever had in my entire career.
It is clear that you are passionate about your research, and I think it's really cool that you highlighted the different areas from like really basic, how are things forming and developing in the kidney, which lead to these kidney diseases in kids, and how are medicines that we use injuring the kidney or bladder, and what are the mechanisms and how could that be, intervened in, and then how we can maybe make new kidneys instead of the treatments we have now. Just a final point, your division, I think, really focuses a lot on research and education, right? That a little unusual for a pediatric nephrology division?
Yes, so first of all, we have 10 MD nephrologists and 2 PhDs in our faculty, which puts us at one of the largest in the country. I can't say we're the largest. But it isn't just the numbers that I think is impressive. We have 4 in our division that are really dedicated to patient care, that really come to work to see patients and stamp out kidney disease, and they do a wonderful job. And then the rest have sort of other activities, mostly focused on discovery and research. And what I love is it's really diverse. So we have my basic science program, but I'm not the only one. We have junior faculty doing really exciting things, R1 funded research focused on the role of microRNAs in kidney and patterning the kidney and podocytes in the glomerulus. We have people working on how the microvasculature is important in response to acute kidney injury and how alterations in metabolism related to the microvasculature is important in acute kidney injury. We have people working on understanding the mechanisms of nephronophthisis, which is a degenerative cystic kidney disease, looking at how aberrant DNA damage response plays a role, which again has potentially high clinical relevance. We have people looking at altered membrane trafficking of proteins in diseases such as nephrotic syndrome. There are lots of kinds of nephrotic syndrome we don't know how to treat, we don't understand the pathophysiology, but this is a novel approach and an outside-the-box thought that aberrant trafficking of proteins contributes to this. And while we have this fairly solidly established basic science program, we have this growing patient-oriented research program that I'm very excited about. We have a faculty member who's a dual critical care pediatric nephrologist who submitted what's called a K Award, which is a career development award. She's likely to be funded. She got a very good score, looking at novel biomarkers that would predict poor outcomes in patients with congenital heart disease that go for heart surgery. So many of these patients, these adult congenital heart patients get their surgery. About half have florid kidney failure requiring intervention. Half don't. We have no idea to predict who's going to do what, which would then help us look at determine how closely we'd follow up on care we give. She has some very innovative data looking at this and is likely to be funded. We have people looking at doing that. We have a faculty member that created a high-density patient database from the intensive care unit from a 5-year period, granular level detail, and has identified novel associations between antibiotics and acute kidney injury that really weren't very appreciated. Piptazo, Zosyn, actually fell out as a very highly associated with acute kidney injury. Vancomycin did not, which was surprising. So this is a current K application that's in review. We have other fellows. I'm very proud to say we're one of only 5 pediatric nephrology programs that has a dedicated T32 to training pediatric nephrology fellows. Only 5 in the country. And of the 13 fellows that have been on the T32, 6 are committed to becoming clinician scientists. And I actually heard rumors that one that's a junior person, a 7th, is very interested. And the topics they're looking at range from hardcore basic science work, one doing induced pluripotent stem cell work, all the way to patient-oriented research related to databases and other things. So I'm very proud of the research focus in our program.
So it sounds like there's a lot going on with kidneys, ureters, bladders, and urethras here in Pittsburgh. We're so happy that you were able to take the time to join us on the podcast today and share this knowledge with us.
It's really been a pleasure to have Carl Bates, Chief of Pediatric Nephrology, to tell us about the exciting research and clinical care in his division. And I'm John Williams. We'll see you next time on That's Pediatrics.
And I'm Steph Dewar. Thanks for joining us.